This is the Emergency Medical Minute.
So we're just going to talk about, guess what, it's not drugs, so you should all be happy about that. I was going to talk about ACS, right? And when I was a medic, back when I was in college, right, we had this acronym for MONA, right? Does anyone know what MONA was?
Morphine, oxygen, nitro, and
Aspirin, great. And what's the only one that matters there? Aspirin, right? We found out that morphine might increase mortality when people are having true ACS, so it's not really a great drug to give. We found out that oxygen really doesn't help anyone and might actually increase bad stuff for patients. And nitrogen, while a great symptomatic reliever, really doesn't change anything with mortality. So we've kind of really started changing our ACS algorithms. And yesterday, or actually a few months ago, there's a paper that came out which also said that more of our armamentarium against ACS might be pretty worthless. And does anyone know kind of the other thing that we're looking at now that might not be that useful in ACS? No? So it's actually heparin. And it's a pretty limited cohort, but they did this really large study in China, 5 different hospitals, 4 years, 6,800 patients, and they looked at patients who were having non-STEMI or unstable angina. So these weren't the people who came in, had a STEMI, and went right to cath lab. These are the people who came in, either had a bump trope or had a really wonky looking EKG and chest pain and got admitted. And traditionally, we used to heparinize those patients, right? They put them on a heparin drip while they waited to go to cath lab. And what they found was in this patient population that they actually had just an increased bleeding rate, but no benefit to mortality. So you just made people bleed more. They really didn't have any better survival or better outcomes. And the reason why that's important is because most of the literature that came out for heparin came out around 25 to 30 years ago. And at that time, what we did was when you came in, you almost never, and you didn't have a STEMI, you almost never went to cath lab. We kept you on heparin for months after you were treated. And that was, at that time, good medicine. But we just don't do that anymore. Since that time, we came up with anti-platelets like Plavix or Brilinta or Tigolor. So really care has shifted, and now the question is, are we just practicing outdated medicine? When people can come in, they have chest pain, you can give them aspirin, you can give them possibly some Plavix, and then the next day they're going to go to cath lab when the cardiologist is awake. So that's kind of what medicine might look like in a few years. Definitely not good enough to change practice, but definitely thought-provoking stuff. And if you're looking for the paper, it's in JAMA, I think in November. Okay, thank you.
Emergency Medical Minute is and always will be about free medical education. Medicine's most prolific podcast is successful because of our supporters, donors, and of course, our listeners. Please like us on Facebook and follow us on Twitter. And if you support spreading free medical education, please donate at our website, emergencymedicalminute.com. As always, keep listening.